Welcome to the Deep Dive, the show where we take the crucial research, the pressing clinical reports, and the really surprising scientific facts, and we deliver the essential knowledge you need, without any of the fluff.
And today we are really opening the file on a disease that is just a study in medical contrasts.
It really is. It's incredibly rare. Most clinicians will never see a case. But at the same time, it's caused by, and this is not an exaggeration, the most potent poison known to mankind.
We're talking about botulism, and specifically the botulinum neurotoxin, or BoNT. In medicine, we throw around words like deadly all the time. But the potency of BoNT, it just transcends those normal superlatives. We're talking about a severe, acute neuroparalytic syndrome. It's so uncommon that, like you said, you might go your whole career without seeing it.
But if you do see it...
If you do, and you fail to recognize it immediately, the outcome can be catastrophic.
And that really sets the stage perfectly for our mission today. We are going deep into the sources to understand this biological menace. Where does it come from? What are the precise conditions it needs to form?
And the mechanism, the way it carries out its attack on our nervous system is just shockingly elegant in a terrifying way.
Exactly. And we'll get into the different clinical forms it can take, and most importantly, the really complex resource-intensive strategies we need to save a life.
And if there's one single piece of knowledge we need to imprint on you right at the top, it is this. Botulism is always a medical emergency. Always. It doesn't matter if it comes from a jar of improperly canned food, a contaminated wound, or, and this is the most tragic, an infected infant. The flaccid paralysis that results is a race against the clock.
So when those symptoms start appearing, difficulty breathing, maybe blurred vision, that classic descending muscle weakness, the urgency is absolute.
It is. That initial clinical picture demands action.
We have to be crystal clear here. If you, as a clinician, or even as a patient, suspect Bomber palsy, so that's trouble swallowing, speaking, moving the eyes, or you see that characteristic descending weakness, the instruction is unambiguous.
Do not wait.
Do not wait.
Yeah.
This is a progressive illness. Every hour you delay is an hour you lose before the critical intervention that's needed to stop that patient from progressing to full respiratory failure.
So to really understand the disease, we have to start with the producer.
The culprit. And the producer is a bacterium with a really fascinating pedigree. Clostridium botulinum. It sounds menacing, but medically, what makes this specific organism and its close relatives, like Clostridium butyricum and C. baratii, such a unique threat?
Well, the uniqueness really boils down to three main characteristics. First, it's a gram-positive, rod-shaped bacterium. Okay, standard enough.
Right.
Second, and this is key, it's an obligate anaerobe.
Meaning it absolutely cannot grow or thrive if oxygen is present.
At all. Oxygen is toxic to it.
Yeah.
And third, and this is the most critical part for human pathology, it is a spore former.
And I think the first surprising fact, when you really look at the epidemiology, is just how common this bacterium is. I mean, it is everywhere in the environment.
Truly ubiquitous. C. botulinum spores. They're literally soil-dwelling organisms. You can easily isolate them from agricultural soil, from river and lake sediments, marine environment.
Even the dust in our homes.
Even the dust in our homes. They're on raw vegetables, fruits, seafood, and that's the paradox you highlighted. Despite being found almost everywhere, it is exceedingly rare for these bacteria to actually make people sick.
Which leads us directly to that protective coating, the spore. If these things are so widespread, why doesn't everyone who eats, say, a raw carrot get botulism?
Because the bacteria themselves aren't the immediate problem. The toxin is the problem. And for the bacteria to produce that toxin, they have to transition from their dormant spore stage to their vegetative, actively growing stage. And that spore is just an evolutionary marvel. It's a metabolically dormant shell designed purely for survival.
And how resilient are we talking here?
Oh, astoundingly so. These spores can survive conditions that would instantly kill the vegetative cell. We're talking about high temperatures, resistance to a lot of chemical disinfectants, even enzymatic digestion in our gut.
Pressure changes.
Pressure changes, exactly. So for most healthy adults, if you ingest some spores, they just pass right through your digestive system, harmlessly. They only become deadly when they find a very specific, very limited set of conditions that allow them to germinate and grow into those toxin-producing bacilli.
Okay, so this is the perfect storm. If you're a public health expert or you're a clinician taking a patient's history, what are those precise environmental conditions, this anaerobic alchemy that has to happen? I think we really need to unpack these factors because they are the foundation of food safety standards all over the world.
Yeah, this list of 6 factors is absolutely essential, and it's the simultaneous presence of all 6 that turns a harmless spore into a lethal poison factory.
So let's start with the absolute non-negotiable factor, oxygen.
You must have a low oxygen or a completely anaerobic environment. As an obligate anaerobe, C. botulinum is inhibited by even trace amounts of molecular oxygen.
So this is why things like commercial canning, vacuum packing, even just wrapping food tightly in foil, they create the initial risk. They remove the oxygen.
They create the first condition, which is why they have to be paired with other protective measures.
Okay, so the next barrier is chemical, acid.
Right. Low acidity is vital for its growth. Specifically, the pH has to be greater than 5.0. That is the magic number in food preservation.
Above 5.0.
If you can keep the food's pH at or below 4.6, through proper pickling or fermentation, that acid environment acts as a definitive barrier. The spores can be there, but they can't grow. It's why highly acidic foods, like most fruits, are naturally resistant.
And then we get into 2 other chemical inhibitors that are related, sugar and salt.
That's right. Both high sugar and high salt concentrations inhibit the bacterial growth. They do it by drawing out necessary moisture. Food scientists call these controlling factors or hurdles.
So it's about creating a hostile environment.
Exactly. If the salt concentration in the aqueous phase, that's the water inside the food, is greater than 3.5%, it's just too hostile for the bacteria to reproduce. And it's the same idea with high sugar concentrations, like in jams or jellies. That osmotic pressure is protective.
So all these traditional preservation methods, they weren't just about flavor. They were actually creating these chemical hurdles that directly addressed the growth requirements for Clostridium.
Precisely. They were effective biological countermeasures centuries before we even knew what a microbe was.
Okay, so the 5th factor is temperature. And we tend to think, refrigeration solves everything, but with botulism, it's a bit more nuanced.
It is. High temperatures will kill the vegetative cells, sure, but we have to distinguish between what we call proteolytic and non-proteolytic strains.
And what's the key difference there?
The non-proteolytic strains are psychotrophic. That's a fancy word, meaning they're capable of growth and toxin production at chill temperatures.
So in the refrigerator?
In the refrigerator, yes. Specifically, 3 degrees Celsius and above. So if you have a vacuum-packed food that's stored just a little bit above optimal refrigeration temps, or if it has a really long shelf life, these strains can present a genuine silent risk even when chilled.
And finally, number 6, water activity. You can't have growth without a certain amount of available moisture.
Right. Water activity, or AW, is just a measure of the free water that's available for microbial growth. For C. botulinum, that water activity typically has to be greater than 0.97.
Very high.
Very high. So if you dehydrate or cure a food enough to drop the water activity below that threshold, you eliminate the threat. All 6 of these conditions have to line up. Low oxygen, low acid, low salt, low sugar, the right temperature, and high water activity. That's what turns a food product into a toxic threat.
And the absolute classic example that ties every single one of those factors together is improperly home-canned vegetables, things like potatoes or green beans.
It's the perfect storm in a jar. The sealing process creates the low oxygen environment. The low-acid vegetables provide the high pH. And if the heat sterilization step, what we call the botulinum cook, wasn't enough to destroy the spores,
then those surviving spores find this perfect, moist, anaerobic home to germinate and just start pumping out neurotoxin.
Exactly.
Now, let's shift to the fact that really elevates this whole topic above just food safety. The toxin's potency. I mean, we need to remind ourselves why bull tea is considered a Category A bioweapon.
The reason is the numbers, and they are staggering. The botulinum neurotoxin is, without question, the deadliest known toxin. We quantify lethality using the LD50, the lethal dose, for 50% of a population.
Right.
For BoMT, the intravenous dose is estimated at only 1 to 3 nanograms per kilogram of body mass.
A nanogram, that's a billionth of a gram.
To put that in perspective for you, if you could take a single milligram of pure BoMT, that's about the size of a grain of salt, and distribute it evenly, that infinitesimal quantity would be enough to potentially kill over 1 million people. It is orders of magnitude more potent than something like ricin or sarin gas. And that fact, combined with its stability and how easy it is to store, is why global defense organizations treat the existence of this poison so seriously.
We also need to recognize that the toxin itself isn't uniform. There's variability.
Right. There are 7 known serotypes designated A through G based on their immunological characteristics. For human botulism, the ones we really worry about are types A, B, E, and F.
And is one worse than the others?
Serotype A is consistently noted as the most potent. It's capable of causing the most severe illness and generally requires the longest recovery time. So understanding the serotype is vital in a public health response because it dictates the specific antitoxin you need to use.
So with the toxin now produced, let's shift our focus to the patient. How does this molecular assassin get into circulation and launch its attack on the nervous system?
Well, the initial path depends entirely on how you were exposed. When we talk about routes of entry, we're generally classifying 4 main types. Foodborne, where you eat the preformed toxin. Wound botulism, where the spore germinates inside your tissue. Intestinal toxemia, which includes both infant and adult forms, where the bacteria colonizes the gut. And finally, iatrogenic, which is through an injection.
And the onset time. That's a huge clinical clue, right? It guides our suspicion about where it came from.
It's critical. For foodborne botulism, symptoms typically pop up between 12 to 72 hours after you eat the contaminated food.
Yeah.
But, and this is but it's highly dose dependent.
So more toxin, faster onset.
Exactly. If a massive amount of toxin is consumed, the onset can be as quick as 2 hours. But if the dose is really low, symptoms might be delayed for up to 8 days. The faster the onset, the higher the suspected dose, and the greater the clinical urgency.
And wound botulism is slower.
Inherently slower, yes, because the spores have to first germinate and then reproduce before significant toxin levels can build up. That often takes between 4 to 14 days.
Okay, so let's move to the molecular battleground. The toxin itself is a zinc-dependent metalloproteinase. It's made of a heavy chain and a light chain. Walk us through how this complex structure targets and then just irreversibly shuts down communication between the nerve and the muscle.
This mechanism is what makes botulism so unique and, frankly, so terrifying. The toxin travels through the bloodstream, but it has a very specific affinity for cholinergic nerve terminals.
Meaning the junctions that release acetylcholine, or HA, to trigger movement and gland function.
Exactly. It's a precision strike, targeting that communication hub.
So the heavy chain is kind of the delivery vehicle.
You can think of it that way. Its role is twofold. First, it promotes the binding of the whole BoT complex to the nerve terminal membrane. And second, it facilitates the uptake of the toxin through endocytosis, basically pulling the whole molecule inside the nerve cell.
So once it's inside, the light chain gets released into the cytosol. And that's the enzymatic killer, right?
Yeah. That is the assassin. The light chain is a highly specific enzyme, and it targets and cleaves proteins that belong to something called the snare polypeptide complex.
We hear the term snare complex a lot in neurobiology. But for the listener, why is this specific protein complex so critical for a nerve to function? And what does the toxin do to it?
The snare complex, which includes proteins like SNAP25, syntaxin, and synaptobrevin, is the essential molecular machinery that physically orchestrates synaptic vesicle fusion.
Okay, break that down.
Think of the nerve terminal as having thousands of tiny bubble-like sacs. These are vesicles, and they're filled with acetylcholine. For you to move a muscle, these vesicles have to fuse with the presynaptic membrane and dump their AC cargo into the junction. That's the signal for the muscle fiber to contract.
So it's like the mechanical trigger for communication. It's the docking machinery.
Exactly. The snare proteins form a complex that literally pulls the vesicle and the cell membrane together, allowing them to fuse and release their contents. The BoNT light chain acts like molecular scissors. It physically cuts one or more of these snare proteins. Bonta, for example, famously targets SNAP25.
And by cutting it, the nerve terminal loses the ability to dock and release those SNF vesicles.
Completely. It's not just blocking the signal, it is destroying the physical pathway for the signal.
And it's an irreversible inhibition.
Irreversible. The nerve is still there, the muscle is still there, but the communication line is permanently severed. And since SE is the neurotransmitter for both voluntary motor movements and our autonomic nervous system, the result is this diffuse, symmetrical, flaccid paralysis.
Now, a key differentiator here. Why is the patient, even when they're fully paralyzed, usually completely clear cognitively, mentally aware of everything?
Because of the blood-brain barrier. The botulinum neurotoxin is a large protein complex. It's too big to effectively cross that protective barrier into the central nervous system.
So the brain is spared.
The brain is spared. This means the patient's intellect, their sensorium, their consciousness, it's all fully maintained. They are, in essence, locked in, which, as you can imagine, is a deeply frightening clinical presentation for the patient.
And that leads to the lasting legacy of this toxin. If that cleavage of the snare proteins is irreversible, how does recovery ever happen?
That's the thing. The damage is irreversible at that initial nerve terminal. The snare proteins that were cut are gone for good. Recovery doesn't happen because the toxin wears off.
Right.
Recovery is a painstakingly slow biological process of neuronal regeneration. The body has to physically sprout entirely new nerve terminals and axon collaterals to bypass the damaged, paralyzed junctions and reestablish communication with the muscle fiber.
And that nerve sprouting process is just inherently slow.
Incredibly slow. It takes weeks to months, and sometimes up to a year or even more, depending on the severity of the illness and the serotype involved. This is why even patients who survive botulism often require such long-term physical therapy and rehabilitation. It's a massive, slow, structural repair project undertaken by the body.
So understanding that core mechanism really allows us to appreciate the variability in how this illness presents. And that's defined by those 5 major routes of exposure we mentioned.
Right.
So let's start with foodborne botulism. This is the classic presentation, the one we all associate with historical outbreaks. This is pure toxemia, just consuming the preformed poison.
And traditionally, this is all about improperly processed, low-acid canned goods or preserved fermented foods. Clinically, because you ingest the toxin, patients often get this initial gastrointestinal prodrome, abdominal pain, nausea, vomiting, within that 12 to 72-hour window.
But the most consistent early symptom is actually constipation, right?
It is. Due to the autonomic nerve involvement in the GI tract, profound constipation is nearly universal as the illness progresses.
And then the neurological symptoms start to descend rapidly, starting at the head and neck.
That descending symmetrical flaccid paralysis is the absolute hallmark. Patients present with what we call bulbar palsies, that's difficulty swallowing, or dysphagia, slurred speech, dysarthria, double vision diplopia, and drooping eyelids, ectosis. If the diagnosis is missed, that paralysis then moves down to the limbs and critically to the diaphragm, which leads to respiratory failure.
And some of the subtle risks continue to pop up in modern food prep. We all know the classic home-canned green beans story, but what about other risks?
The foil-wrapped baked potato is a perfect case study.
Yes.
If you wrap a potato tightly in foil and bake it, that internal environment becomes anaerobic. If that potato is then just held at room temperature, not put in the fridge, any resident spores can germinate and produce toxin. Same thing with homemade oils infused with garlic or herbs. They exclude oxygen, and unless they're properly acidified and refrigerated, they become a perfect growth medium.
Okay, so let's move to a more modern clinical challenge. Wound botulism. This is really where the environment meets a specific risk behavior.
Absolutely. Wound botulism happens when the spores get into deep, necrotic, or devitalized tissue, basically, tissue that has become anaerobic. Now, it can happen after a traumatic injury or surgery, but its prevalence really increased dramatically with the rise of injecting illicit drugs.
Particularly black tar heroin.
The injection process itself and the impurities in the drug create those ideal low oxygen, low pH pockets for the spores to germinate and produce toxin directly in vivo inside the body.
And this form has a crucial clinical difference from foodborne botulism, doesn't it?
Yes, and it's a key diagnostic point. Wound botulism is the only variant that commonly presents with fever and localized signs of infection, like an abscess or cellulitis at the wound site. That's because you have the vegetative bacteria actively proliferating in the tissue.
And that infection signal can actually be a red herring. It can distract clinicians from the real problem.
It can. And crucially, the GI symptoms that are so common in foodborne botulism are usually absent in wound cases.
All right, next up, we have to address the single most common form in the United States. Infant botulism, often called floppy baby syndrome. The numbers are just staggering. It makes up over 70% of all the cases we see annually.
It's a devastating diagnosis. It typically affects infants between 2 and 8 months of age. And unlike foodborne cases, these infants are not ingesting the preformed toxin, they're ingesting the spores.
From environmental dust or contaminated food.
Right, and the illness happens because the infant gut is physiologically vulnerable.
How so? How does an infant's gut differ from an adult's in a way that allows this to happen?
The infant gut microflora just isn't mature yet. They lack the full competitive inhibition that you get from a robust, diverse adult microbiome. They may also have lower levels of bile acids, which normally help suppress C. botulinum growth. So this allows the ingested spores to colonize the intestinal lumen and start producing toxin in situ.
So as a caregiver or a pediatrician, what should you be looking for in terms of how the symptoms progress?
The onset is often very subtle, but it's inexorable. It usually begins with constipation, just a persistent, unexplained inability to pass stool. That's followed by lethargy, poor feeding, a diminished suck and gag reflex, drooling.
And then the hypotonia.
Then the global hypotonia, or the floppy baby presentation, quickly ensues. And that demands immediate, high-level respiratory monitoring.
And we have a very recent public health event that just underscores how quickly an environmental source can become an acute risk. The infant formula outbreak that was developing as of late 2025. Tell us how that public health investigation unfolded.
This case is a perfect illustration of epidemiology and critical care intersecting. We started seeing an alarming cluster of infant botulism cases across multiple states.
Right.
So epidemiologists went out and interviewed the parents of the 23 hospitalized infants. And they found a disproportionate representation of one specific product, By Heart Whole Nutrition Infant Formula.
And the math on that correlation was what really blew the case open.
Absolutely. The formula in question held only about 1% of the total U.S. infant formula market share.
Tiny.
Yet, over 40% of the sick infants who had been exposed to powdered formula had consumed that specific brand. That extreme statistical overrepresentation was the immediate alarm bell. You just couldn't explain it by chance alone.
The implication was clear. The product had to be contaminated with spores.
Correct. The CDC and state health departments immediately initiated a massive investigation and recall, and preliminary lab testing from one open can that was fed to a sick infant in California later confirmed the presence of C. botulinum bacteria. It just highlighted a major failure somewhere in the manufacturing or packaging process that allowed spore contamination. It's that coordination of clinical suspicion and epidemiological data that led to a rapid protective response.
Moving to the rarest, but I think increasingly relevant forms, iatrogenic botulism. This one is directly related to the therapeutic use of the toxin.
That's right. Iatrogenic botulism is caused by the medical or cosmetic injection of botulinum toxin, Botox, Dysport, things like that. Now, it's usually very safe and localized therapeutic doses, but systemic botulism can result if too large a dose is administered or if the toxin spreads beyond the intended injection site.
So what are the key symptoms that would indicate a systemic spread after an injection like that?
Patients might report symptoms hours to weeks after the procedure. Things like a persistent headache, uncharacteristic muscle weakness, dysphagia, or diplopia. The FDA has actually issued black box warnings for all Bol-in-T products because severe cases, including some fatalities, have occurred due to the systemic spread, requiring aggressive supportive care.
And finally, there's adult intestinal toxemia.
This is an extremely rare analog to infant botulism. It's where spores colonize the adult intestinal tract and produce toxin in vivo. It usually requires some form of underlying compromise to the gut.
Like surgery or a chronic condition.
Exactly. Recent GI surgery, chronic inflammatory conditions, or even long-term antibiotic use that has severely disrupted the normal gut flora, allowing the Clostridium to get a foothold and flourish anaerobically.
Okay, so given the potential for this rapid progression to respiratory failure, the diagnostic process here can't wait for lab confirmation. It has to be driven by an immediate, high clinical index of suspicion.
This is a clinician's diagnosis. It's based on history and physical exam first and foremost. Laboratory confirmation, which usually requires these complex mouse bioassays or advanced PCR to identify the toxin, can take days. The patient may not have days.
So we have to rely on the classical clinical triad.
Yeah.
What are those three pillars that should make a clinician think botulism and act immediately?
Okay, number one is the pattern of paralysis. Bulbar palsy progressing to descending symmetrical flaccid paralysis. Cranial nerves first, then moving downward.
Right.
Number two is the absence of fever. This is what distinguishes it from most infectious diseases. The only exception, of course, is wound botulism.
Right.
And number three is the preservation of clear cognition and mental status, confirming that the blood-brain barrier is intact.
So let's detail that progression of symptoms that a clinician really needs to identify early.
Early symptoms are often really subtle. A patient might just report blurred vision or double vision diplopia. This can then progress to ptosis, the drooping eyelids, and facial weakness. A particularly key sign is fixed and dilated pupils. That reflects paralysis of the short ciliary nerves due to the loss of ACE release.
And that bulbar involvement then quickly impairs their ability to protect their own airway.
Exactly. The ability to swallow and clear secretions is compromised, which is why intubation often becomes necessary long before there's complete respiratory muscle failure.
Now, this descending flaccid paralysis, it's a real diagnostic conundrum because it mimics other serious neurological emergencies. We have to nail the differential diagnosis.
We do. The primary conditions we have to rule out are Guillain-Barré syndrome, or GBS, myasthenia gravis, and Lambert-Eaton myasthenic syndrome. The treatments are drastically different.
So what is the most reliable clinical tool to differentiate GBS from botulism quickly at the bedside?
The progression pattern. GBS classically presents with ascending paralysis. The weakness starts in the legs and moves upward. Botulism is definitively descending. It starts in the cranial nerves and moves downward. Also, GBS patients often have sensory symptoms, tingling, numbness, whereas botulism patients typically do not. They maintain full sensation despite the profound motor weakness.
And we can use electrophysiological studies, EMG, and nerve conduction studies to support our suspicion while we're waiting for those definitive toxin results.
Yes, they can be highly supportive. We look for patterns of neuromuscular blockade. Classical findings include a reduced amplitude of muscle action potentials after you stimulate the nerve. We also look for something called post-tetanic facilitation, where high-frequency stimulation causes a transient increase in muscle response. It's a finding that occurs in both botulism and Lambert-Eaton because they're both diseases of presynaptic failure.
So once that suspicion is high, we transition immediately to treatment, the race to neutralize. What are the logistical steps? This isn't a drug that's just sitting on the average hospital pharmacy shelf.
Oh no. The immediate step is to activate the public health apparatus. This means calling poison control and your state health department. They, in turn, contact the CDC Director's Emergency Operations Center. The CDC is the central authority that maintains and releases the critical resource, the antitoxin.
And the primary goal of that antitoxin therapy is neutralization, but we really have to emphasize its limitations.
We do. The antitoxin is made of antibodies that bind to and neutralize any circulating BoNT that's still in the patient's bloodstream. This stops further nerve damage by preventing the toxin from binding to new nerve terminals. But, critically, it does not reverse any damage that's already been done to the snare proteins.
So once the toxin is bound, it's a permanent blockade. The patient still has that long recovery ahead of them.
They do.
And the antitoxin preparation itself differs depending on the patient's age.
That's right. For adults and children over the age of 1, we use something called the heptavalent equine serum antitoxin, or HBA. It targets serotypes A through G. Now, this is equine-derived, meaning it comes from horses, so we have to monitor the patient very closely for hypersensitivity reactions, including serum sickness and potentially fatal anaphylaxis.
Yeah, for the most vulnerable patients, the infants, there's a human-derived product that's preferred.
Yes. Infants under 1 year receive botulism immune globulin, or Baby Big. This is derived from the plasma of human donors who have high levels of neutralizing antibodies, and the data clearly shows that giving Baby Big promptly significantly shortens the duration of the illness and the need for mechanical ventilation in infants.
So beyond the antitoxin, the cold, hard reality of botulism management really lies in supportive care. We need to detail the extensive requirements for a patient who might be completely paralyzed for weeks or even months.
This is where modern medicine really shines, and it's why mortality rates have plummeted from, 70% down to single digits. These patients require aggressive, high-acuity care in a specialized intensive care unit. The moment a patient's vital capacity drops below 30% of what's predicted for them, intubation and mechanical ventilation have to be implemented.
And what does long-term ventilation involve, practically speaking?
It is an immense commitment of resources and specialized care. Many patients will need a tracheostomy placement to manage secretions and reduce the risk of long-term vocal cord injury or pneumonia. We have to aggressively manage their nutritional needs, usually with a feeding tube, since they can't swallow. And they're at high risk for all the secondary complications: ventilator-associated pneumonia, deep vein thrombosis, pressure injuries from being immobile.
So the ICU team isn't just managing the paralysis. They're managing all the myriad complications that come from being immobile and on a ventilator for extended periods.
It requires a dedicated interprofessional team. You need intensivists, respiratory therapists, dietitians, neurologists, specialized nursing staff. Survival really depends on meticulous attention to all those details over months, while you're just waiting for those nerve terminals to sprout back.
Finally, we have to clarify a really critical antibiotic caveat. Why is killing the bacteria in certain forms of botulism actually a dangerous therapeutic error?
This is essential for clinical practice. Antibiotics like penicillin G or metronidazole are only used for wound botulism.
Only wound botulism.
In that scenario, the goal is to kill the vegetative cells that are proliferating in the anaerobic wound tissue and stop the ongoing production of new toxin.
But in the other forms, especially infant botulism or foodborne botulism, the danger completely reverses.
Exactly. In intestinal or foodborne cases, the toxin has already been produced. If you give broad-spectrum antibiotics, you can cause rapid lysis, the bursting open of the Clostridium bacteria. This leads to a massive, rapid surge of preformed BoNT being dumped into the system all at once.
Which could be catastrophic.
It can dramatically worsen the patient's condition, potentially causing acute respiratory compromise. You treat the toxin first. Then, if you need to, you treat the infection second, but only when it's appropriate.
And one final pharmacological warning. Magnesium salts.
Yes. Magnesium salts, which are often used in obstetrics or for certain cardiac conditions, must be strictly avoided. Magnesium ions naturally potentiate or enhance the neuromuscular block that's already caused by the botulinum toxin. They can dangerously increase the degree of paralysis.
So moving from the bedside to the public health system, let's talk about prevention. Since the spore is so incredibly resistant to heat, food safety relies on these specific industrial controls known as the botulinum cook.
Right. The thermal resistance of that spore is what necessitated the adoption of extremely high standards for commercial processing. The benchmark is a process that achieves what's called a 12-log reduction of C. botulinum spores. For commercial low-acid canned foods, this means making sure the slowest heating point inside the can reaches 121 degrees Celsius or 250 Fahrenheit and is held there for at least 3 minutes.
And for home canners, who are often the source of these outbreak cases, the instruction is just as strict.
Home canning absolutely requires a pressure cooker. You have to reach those 250 degree Fahrenheit temperatures for an extended time, anywhere from 20 to 100 minutes, depending on the food's density and the container size. And crucially, if there is any doubt about the safety of a home canned food, or if the lid seal looks compromised, that food must be boiled vigorously for at least 5 to 10 minutes before anyone tastes it or serves it.
And boiling won't kill the spores, but it does something vital to the toxin that's already been formed.
Correct. The preformed toxin itself is heat labile. It's destroyed by heat. So boiling inactivates the poison, providing a final layer of protection, even if some heat-resistant spores survived the initial panning process.
Now let's talk about modern packaging. Specifically, vacuum-packed or modified atmosphere-packed chilled foods. Since these exclude oxygen, they represent a latent risk that has to be managed with regulatory hurdles.
This is a really sophisticated area of food science. Since MAP and VP create the anaerobic condition that C. botulinum needs, regulators have to impose strict limits on shelf life unless specific safety hurdles are met. The baseline is a maximum 10-day shelf life when it's stored at proper refrigeration temperatures.
And what are the main controlling factors that would allow a manufacturer to extend that shelf life beyond 10 days?
They have to employ a validated hurdle system. So these hurdles could include a heat treatment equivalent to 90 degrees Celsius for 10 minutes, or maintaining a low pH, 5.0 or less, or a high salt concentration, greater than 3.5% in the aqueous phase, or extremely low water activity. If none of those single hurdles are met, the food business has to validate that a combination of factors, like a little bit of salt and low temperature, provides the necessary protection for the intended shelf life.
It's important to note the specific guidance on raw meat, though, which seems to be treated a little differently.
Yeah, fresh, raw cuts of VPMAP, beef, lamb, and pork are generally considered low risk for non-proteolytic C. botulinum compared to processed foods. While no outbreaks have been definitively linked to these specific products, voluntary industry guidelines often permit a 13-day maximum shelf life under specific handling protocols. But once that meat is processed minced, cooked, mixed with spices, the strict 10-day or hurdle requirements apply all over again.
And for infant prevention, the rule is simple and absolute.
Avoid honey in children younger than 12 months. Honey is a well-known environmental reservoir of C. botulinum spores. While environmental dust causes the majority of cases, honey ingestion accounts for about 1/5 of all confirmed cases of infant botulism.
We've touched on the prognosis, but let's just celebrate the reality of recovery here.
The drop in mortality from 60 or 70% down to 3 to 7% is just an enormous public health victory. And it's entirely attributable to aggressive supportive care, mechanical ventilation, and modern ICU resources. But that recovery is measured in months to years, not days. The journey requires real dedication from an entire interprofessional team.
What are the key long-term services that are needed beyond that acute ICU stay?
Well, after the acute phase, patients frequently need intensive physical medicine and rehabilitation to address the muscular atrophy and profound weakness. Speech pathologists are crucial for patients recovering from bulbar palsy and tracheostomy placement. And chronic fatigue is a very frequently reported long-term symptom. The management really shifts from just survival to optimizing the quality of life while the nervous system painstakingly repairs itself.
Finally, we have to turn to the really unsettling reality that elevates BoNT into the realm of geopolitics.
Yeah.
Its potential as a weapon of mass destruction.
This is the dark side of the toxin's potency. Because of that infinitesimal LD50, BoNT is classified as a category, a biological threat agent by international defense and health organizations. It just requires so little material to achieve mass casualties, and it can be pretty easily aerosolized or introduced into food supplies.
And we know from our sources this is not just a theoretical threat. It has been actively pursued by nation-states and non-state actors.
Historically, yes. The United States CIA had an active biological warfare program involving BoNT. More recently, Iraq admitted to producing several thousand liters of concentrated BoNT during the Gulf War period. They codenamed it T and even loaded it onto military weapons systems, though thankfully they were never deployed.
And the terrorist organization Aram Shinrikyo tried to use it repeatedly in the 1990s in Tokyo. They only failed because of technical difficulties with their dispersal mechanisms.
The fact that such a potent toxin is relatively stable, can be acquired through isolation techniques, and is easy to store, it just makes vigilance absolutely essential. Any unusual cluster of flaccid paralysis cases, especially if they're linked to a common exposure, requires an immediate investigation for an intentional release.
So we've completed a really comprehensive deep dive into botulism, covering everything from the unique growth requirements of this anaerobic spore to the intense, long-term supportive care that's required in the ICU.
And our synthesis, I think, confirms 3 critical takeaways. First, the sheer lethality and the unique molecular targeting of the BoNT, that irreversible cleavage of the snare proteins, that's what makes recovery so dependent on neuronal regeneration rather than a pharmacological fix.
Right. And second, the clinical presentation is just so diverse. It ranges from classic foodborne outbreaks and infant colonization to modern risks associated with black tar heroin and even cosmetic procedures. It demands a high index of suspicion from every single clinician.
And third, that massive reduction in mortality. It's a testament not just to the antitoxin, which stops the damage, but to the heroic commitment of specialized intensive care teams who manage the supportive needs of a paralyzed patient for months on end.
So to leave you with one final provocative thought, just reflect on the incredible duality of this poison. The very same molecule that can paralyze your diaphragm and demand weeks of mechanical ventilation is meticulously purified, controlled, and used therapeutically as Botox to treat everything from wrinkles to chronic migraines. And it operates on the exact same molecular mechanism.
The difference between the deadliest toxin on Earth and a powerful tool in medicine is solely a matter of concentration, precision, and localization. It really forces you to acknowledge that in biology, the line between a poison and a profound healing agent is incredibly fine, and it is always dependent on the dose.
Until next time, maintain that high index of suspicion and keep questioning the biological world around you.